So we are about to start. Are you ready?
Yes, sir. Am I clearly audible, sir?
Absolutely clear and audible, sir.
Fine.
No issues. We are live on YouTube. Let's start. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 16G, which is Hematology Non-Neoplastic Lesions of WBC. We are streaming live from AIIMS Bhubaneswar via Kolkata. A very interesting topic today, hematological manifestation of acquired immunodeficiency syndrome. And to talk on that, we have somebody who is an expert in hematology, Dr. Somanath Padhi. He is an MD. Presently, is an associate professor in the Department of Pathology with laboratory medicine at the famous AIIMS Bhubaneswar. He's got a post-MD teaching experience of more than 15 years and has been the life member of Indian Association of Hematology and Blood Transfusion, Indian Association of Pathology and Microbiology, and the famous Indian Myeloma Academic Group. His areas of interest are hematopathology and lymphoreticular pathology, pathology of the bone marrow, plasma cell myeloma, hemophagocytic lymphohistiocytic syndromes, and leukemic cytogenetics. He's got more than 50 publications in national and international index journals, and he has been an author of 3 book chapters. Before I ask Dr. Somanath Padhi to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. We are live on YouTube and we are good to go. Sir, please share your screen. Let's start. Thank you so much. Yeah, I can see your screen. Please share your PowerPoint and we will start.
Am I seen now, sir?
Yeah, just make it full screen and press that hide. Yeah, please make it full screen. Yeah,
Yes.
yeah, perfectly fine, sir. Perfectly fine. Please start. Thank you.
Good evening, everyone. First of all, let me extend my heartfelt thanks to the team Pursue, especially Professor Dr. Nadeem, for these wonderful opportunities, and my department colleagues, as well as my colleagues from my previous institute of Pondicherry Institute of Medical Sciences, where I have gone through this topic as well as seen some cases where that when I actually developed some interest. And thank you so much, sir, everyone, and my teachers. So today I'm going to speak on hematological manifestation of acquired immunodeficiency syndrome, and I will be speaking on this topic on diverse aspects over a period of 45 to 1 minutes to 1 hour maximum. And so this is my beginning slide, and as all of you know that this slide is of this is world map, and you have this that in 1959 there was the Kinshasa zone that is known as Kinshasa Island in the Democratic Republic of Congo in the Central Sahara, Central African continent, where this with hunting of these chimpanzees as well as monkeys, there was some transmission of an unique type of immunodeficiency virus, which was at the time called as simian immunodeficiency virus, or SIV. And since then, as you can see that this Congo is surrounded by a lot of sea routes, a lot of river routes, and then that migrated from that region, this viral infections migrated through different parts, and ultimately before it reached in the United States and in 1981, that was the first clinical manifestation of an undiagnosed disease or syndrome where some gay homosexual males, they developed something called as Kaposi sarcoma, as well as pneumocystis carinii, which is now called as pneumocystis jirovecii pneumonia. at Los Angeles as well as New York at the same time. And since then, since 1981, what the disease has now spreaded to almost all parts of this world, and there is virtually no countries left which is where there is no HIV what we are dealing today. Whereas the world has seen two major pandemics, which was characterized by fear among all, and in 2019 we also saw some unusual interaction between humans and these animals in the form of so-called bat, presumably the bat, and in the Wuhan of China in 2019, December 2019, which and there was an outbreak of this most severe pandemic known as SARS-CoV-19. These two viruses, retroviruses, they have a similar morphological appearances. As you can see that both are having a lot of spikes in their surface, and one is one presumably has led to another big pandemic which we are presently dealing with this. So with this background, you can know that the timeline of events of HIV/AIDS, this, as I said, 1959 was the onset of the symptomatic sporadic cases in this central Congo, and which was followed by in the 1981 that was the diagnosis of Kaposi sarcoma and Pneumocystis carinii pneumonia in the gay men. And in 1982, there was a classical risk factors of the humans were described as 4H club: homosexuals, hemophiliacs, heroin addicts, and Haitians, those who are migrating from Haiti. And at the time, the AIDS name acquired immunodeficiency syndrome was, which was a lymphadenopathy associated virus, was called, which was called as a terminology was changed to acquired immunodeficiency syndrome. And in 1983, this Louis Pasteur Institute in Paris first isolated this virus, and which was officially named as human immunodeficiency virus in 1986. And this FDA officially approved this usage of first antiretroviral drug called as Judobudin, and US FDA as well as National Institute of Health also gave green signal to the use of the specific diagnostic test known as Western blot technique for the diagnosis of HIV. So in 1986 also the famous the infectious disease expert, which is also presently, he is also there as an infectious disease the health physician to the US President Anthony Fauci. He was there at that time, and he is also present at this time also at the both viral infection pandemics. And their group categorized these HIV infections as per their stages of these HIV infections. And as you can see that CDC1 was known as highly contagious disease. Patient is apparently well. Just recent seroconversion of has happened, and they are the most infectious stage. And in CDC2, the patients are well with no evidence of generalized lymphadenopathy. And CDC category 3 was presence of generalized onset of generalized lymphadenopathy, as defined as lymphadenopathy involving three major anatomic sites outside the inguinal region, and was called as generalized lymphadenopathy. And then the CDC4 was the acquired immunodeficiency syndrome or the AIDS related complex, which was subcategorized as given different codes as CDC4A, which was prolonged fever and significant weight loss and unexplained without any cause of diarrhea in 4A, and that then subsequently neurological manifestation as CDC4B. Then all sort of opportunistic infections that we come across with or likely to come across with HIV infection is CDC4C. And then came this CDC4D that included this AIDS defining neoplasms like primary CNS lymphomas, and all those neoplasms that were included as 4D. And then comes this other neoplasms, non-hematological neoplasms involving virtually every anatomic sites in an HIV positive patients were categorized as CDC4E. So as I when I was going through the literature, then I just this is my what I searched that hematological manifestation in HIV, and as you all can see that since 1985, 81 was the first case reports in Los Angeles, and from 1985 till 2022, and this HIV and hematology papers, there are almost 3,332 papers, both abstracts, full texts, case reports, case series, reviews, meta-analysis. Altogether, it was around 332 papers have been published. As you can see that the bar diagrams are piling up in 2022, and of course, it is now is being superseded by this COVID-related lot of papers. And when we are talking about this things of HIV hematology, it is very interesting and surprising that before 1990, actually this the electron microscopic evidence of this infection of HIV and the bone marrow changes was actually proven. And in 1999 also, and one of the Indian studies by Dr. Ghosh, also they also had done some electron microscope studies from India also. So nearly 10 papers were found which highlighted this electron microscopic evidence of HIV infections inside the bone marrow. And when I searched these bone marrow changes in HIV/AIDS in the same period, 1987 to 2022, also I found that nearly 71 papers which have been published in various PubMed index journals. So let's start with what are these ultrastructural evidences which have been also found in different experimental studies that HIV actually infects in the human bone marrow cells. So in 1992, this paper came by this Vikrama Singh and group from this United States of America, and the authors in that study included 9 patients, including only one female, and rest all were males. Most of them were Caucasians, and the risk category, as you can see, that there was high risk category based upon this mode of transmission, and almost all were in stage 4 category of HIV/AIDS, and most of these patients have a CD4 cell count was less than 500, and you can see that some of them had also CD4 cell count of 2, then some had 90s. All those things have severely reduced CD4 positive T cell count. And these are the reasons for bone marrow aspiration: thrombocytopenia, pyrexia of unknown origin with pancytopenia, thrombocytopenia, pyrexia of unknown origin, organomegalies, weight loss, anemia. So the evaluation of cytopenias and pyrexia of unknown origin were the main indications of their bone marrow examination in these type of patients. And so this is what the ultrastructural evidence that was found, and these authors, they correlated at that time with this light microscopic evidence of this bone marrow, both in bone marrow aspiration and trephine biopsy morphology. As you can see here that the presence of this yellow, this main structures which are highlighted in this yellow things, is that this multivesicular bodies in lymphocytes. As you can see that there are presence of membrane bound structures which contains numerous slightly electron dense deposits, substances inside it. And as you can see here in the lymphocyte membrane, there is some sort of a protrusion of something known as viral bodies, known as viropods, and there is a protrusion like cells structures which are into the lumen from the membrane of this lymphocyte, which is membrane bound structures. And these are the presence of these multiple vesicular bodies. And though these type of bodies are also can be seen in a normal uninfected HIV uninfected person, but these numbers were markedly increased in patients with these HIV infections. The second most important characteristic features that described in this group of patients is that presence of this type of cylindrical confronting systems and in the macrophages. The macrophages showed the numerous this type of tubular test tube like systems, which are very characteristic feature of this HIV infection of the macrophages. And then comes the most characteristic, even the authors considered this to be a most specific morphological electron microscopic evidence of presence of this type of tubulo-reticular structures, or TRS. There was obvious evidence of cytoplasmic vacuolations in almost every lineage of hematopoietic cells, as well as in these endothelial cells, fibroblast, the accessory cells of the stromal microenvironment, and plasma cells also. There are presence of numerous these vacuoles, which was also evident. And there was in the erythroid lineage, early erythroid precursor, they showed numerous through and through clepting of this nuclear membrane in the erythroid, multiple nuclear membranes clefts or indentations that was and described in this electron microscopic photographs. And to when this and all these features at that time also this correlated with presence of this in light microscopy in this erythroid. There was prominent erythroid vacuolation, cytoplasmic vacuoles were obviously seen on aspirate. Nuclear membranes were irregular, as well as the presence of bi and multinuclearity. These three were the dominant manifestations in the erythroid lineage in the bone marrow aspirate findings. And there were presence of dysplastic granulocytes, dysplastic megakaryocytes, which I will be showing in the next slides. And there was a presence of numerous plasma cells. Plasmacytosis was also very much well evident at the time, and they showed that the plasma cells were morphologically atypical in nature, and there was presence of prominent vacuolation as well, and there is enhanced activity of the macrophages, which was described. Then in 1996, so there was an sufficient evidence that this HIV infection, that after it infects CD4 T cells, which is the receptor for the HIV infection, and this suppresses this CD4 T cells and produces depletion of the CD4 T cell count. And there is an immunological, and also there is presence of infection of lot of cells, both hematopoietic as well as non-hematopoietic cells in the marrow. That leads to a lot of cytokines productions that probably impairs hematopoiesis. This was the initial theory that was described. However, subsequently in 1996, this Moses and their colleagues, Moses and their group, they that human immunodeficiency virus infection of bone marrow endothelium, it reduces induction of stromal hematopoietic growth factors. It was a cell culture based study, and they said that they found that these authors demonstrated that the bone marrow microvascular endothelial compartment, that is MVEC, is a main, as a renowned, or is a key component of this stromal microenvironment, and which is predominantly infected by HIV infections. So they also validated the previous electron microscopic evidence by this Wickramasinghe and group, that these microvascular endothelial cells in the stromal microenvironment are key targets of HIV infections, and up to 20% of these endothelial cells were infected. And when they found that these HIV infected stromal cultures, when they were enriched with HIV's infections, they also express normal level of interleukin 4, interleukin 6, GCSF, and granulocyte monocyte colony-stimulating factor, tumor necrosis factor alpha, TGF beta, and all the factors. However, when these cultured cells, endothelial cells, were subjected to interleukin 1 therapy or treatment, they did not show, or there was a reduction in the release of these some important cytokines like interleukin 6 and granulocyte monocyte colony stimulating factor, which was reduced in these cultures in response to interleukin 1 alpha stimulation. So these observations, they suggested that HIV infection of bone marrow microvascular endothelial cells reduces the capacity of hematopoietic stroma to respond to regulatory signals that normally augment blood cell production during periods of increased demand. Even if they express all these markers of certain cytokines, there was a defect in the regulatory mechanism for which these cells could not release the certain important growth factor necessary for normal hematopoietic cell maturation and development. And as you can see in this diagram, you can see that this is what is the response to the response of interleukin 1 alpha and the GCSF released by the cells. This is normal endothelial cells, and these are HIV-1 infected endothelial cells. As you can see that they will less than 200 CD4 cell count versus CD4 more than 500, and there was a significant reduction in the GCSF release in contrast to the normal endothelial cells. And even in response to the CD4 T cell count, that was also significant decrease in this production of the GCSF, which was very statistically significant. And all the lineages, comes the interleukin 6, then comes the GM-CSF. Their production in response to interleukin 1 induction was significantly reduced in comparison to the normal endothelial cells which are not infected with HIV. And CD4 T cell count has a significant association with this release of these cytokines, which are growth factors for in this cell culture studies. That means at that time also the first evidence or the initial preliminary definitive evidence was there that CD4 T cell count is a significantly marker of this endothelial cell function also. Now, to the further substantiate that this HIV, how this once HIV infection occurs, this landmark study came in the eLife, this microbiology and infectious disease in 2019, and this Ladinsky et al. That hypothesized in this again this experimental studies that came up that once this HIV reaches bone marrow, how does it disseminate? How does it disseminate inside the bone marrow? And they use this known as this bone marrow, liver, and thymic mice, and they found that these macrophages are the principal subset of HIV-1 P24 producing cells. The bone marrow macrophage is the primary source of these infections, and there is just three modes of HIV dissemination in the bone marrow. One is there is a semi-synchronous budding from the T cells and macrophage membrane. There is a budding that happens from the T cells and macrophage membrane. Mature virus that undergoes a lot of this virus macrophages engulfing HIV positive, HIV-1 positive T cells. They keep on proliferating. There is intracellular production of a lot of viral elements, and there is also an access to the extracellular space that leads to the release and further infection of these target cells. So there is also, and the next diagram what I'm going to show is that you can see that this is this mice, that bone marrow, liver, and thymic mice, and the number of cells per cubic millimeter left hand side. And you can say that see here that days of post infections, and there is CD68 positive cells. You can see that which is highlighted in the red bar is increasing with days of infections. That means there is increase in number of macrophages first of all, and you can see that there is a subsequent depletion of the CD4 positive T cells, which is also there, and there is initial stages of these green triangles are this P24 positive infective cells. And as you can see the next diagram, you can see that there is subsequently this the virus starts proliferating, and there is increased number of this viral positive cells, which is highlighted in the greens. There is a depletion of CD4 positive T cells that is there, and the three taller this bar diagrams of red that highlights increased number of CD68 positive macrophages. So as we all know that this is an electron microscopic photograph. You can see that this is what is known as microvascular endothelial cells and the stromal microenvironment. This is a blood vessel sinusoid. You can see that different types of cells which are surrounding this endothelial cells: T cells, megakaryocytes, these macrophages, neutrophils, dividing stem cells, the progenitor cells, WBC platelet. All the cells are there around the blood vessels or sinusoids, perisinusoidal distribution inside the bone marrow environment. And you can see that these are the cultured cells, and this is this right hand panel, which is first one upper corner is known as a T lymphocyte scanning electron microscopic photograph, and this is the confocal immunofluorescent microscopy photograph of a CD4 positive T cells, which is normal. And the lower panel three ones are this bone marrow macrophages, the scanning electron microscopic images of this macrophages, which has a very complex internuclear connections that is highlighted in, and lot of cytoplasmic content. That is, these are the normal morphological findings in this these are the normal features. Now, what happens in this, the first hand, this is A and B. You can see here that in an HIV infection, when HIV infects the T cell, there is what is happening is that you can see that this is fluorescent. There is a something called as a membrane protrusion of this HIV-1 bud, and there is a very significantly reduced amount of cytoplasm between the plasma membrane and the nuclear envelope, and there is a release of this budding is happening and this infected T cells. And in the C and D is showing that there is an infected macrophages, that is also showing one macrophage membrane is also giving rise to numerous budding of this HIV positive cells, which is also highlighted by this fluorescent dyes. And then comes, this is yours the cells which are once there is there, and there is lot of in the lower panel, as you can see that there is presence of synapses is being formed. And the right lower panel, you can see that this is an macrophage which is a donor cell which is releasing lot of HIV-1 buds, which is highlighted in this yellow dots at the site of synapse, where it is synapsing with the target cell. And there is a migration of this HIV positive buds inside the extracellular space, and that same macrophage is also helping this infective forms to again attack and attach to the target cell population. So this is a concrete evidence that this infection of this HIV infection has several mechanism of dissemination inside the marrow environment. Virtually any cell can be affected by this, infected with this HIV infection. Now, with this, we are now sure that there is a definite evidence of both in the ultrastructural evidence that HIV resides in the bone marrow hematopoietic progenitor as well as accessory or stromal microenvironment. There is no doubt about that. Now we will go to this what exactly happens into this hematological things. So let's start with routine hematological abnormalities. And this study is from this is 2021 latest study paper by this Damty and his colleagues, hematological abnormalities of adult HIV infected patients before and after initiation of highly active antiretroviral treatment at a Tabor Comprehensive Specialized Hospital study in Ethiopian study. And as you all can see that there is a very significant association, there is a significant difference between this all the CBC parameters starting from that we can see that CD4 other than everything is there is significantly different between the two groups, and there were very high number of cases. They have studied 334 before, the number of patients were 334 patients, and you can see that this mean corpuscular volume, which was 87.17 femtoliter before initiation of highly active antiretroviral therapy, heart therapy, and it has gone up to 100.6. So that means there is an evidence of macrocytosis that is also not seen following this initiation of heart therapy at least 6 months, after 6 months. So all these parameters, the ANC count has gone down, this absolute lymphocyte count also gone up, CD4 T cell count after HRT retroviral therapy has also gone up from 161 to 381. That means there is a release in this there is a block, there is a release of the block which has happened, or there is in the CD4 T cells. So all these findings were were important. And this is one from the our Indian study, from the recent study from the Jammu, from a labs which were they have taken these samples from 120 positive HIV positive patient without any evidence, without any history of antiretroviral drugs therapy. As you can see that this group has studied that there is an association of the hematological parameters with the CD4 count. As you can see here that there were 44 subjects with a CD4 T cell count of less than 200 and 65 subjects with a count within 200 to 499, and 11 subjects had a CD4 T cell count of more than 500. So hemoglobin level is rising, and there was a statistically significant association with this CD4 T cell count. Those with a high CD4 T cell count has a higher hemoglobin, and similarly the absolute lymphocyte count also, which was there was a significant increase in absolute lymphocyte count percentage with those which have a more CD4 positive T cells, whereas and it is significantly lesser in those with a CD4 T cell count of less than 200. And this value was 0.018, which was statistically significant. And also there is a significant difference in the platelet count in reason to in response to CD4 T cell count. However, this study did not show any evidence of this other CBC parameter. There was no mention about this other morphological findings in the peripheral smear, all those things. And this study from this Parinita and Kulkarni, they from this in Dharwad and in the India as well as in Hubli, they have seen that some again this those they have taken 250 subjects with HIV/AIDS without any antiretroviral therapy. Those rather they have excluded those group of things. They wanted to study this effect of this HIV and hematology per se without any impact of this. Antiretroviral therapy. 200 and anemia was seen almost in 84% of cases, and this was mostly normocytic normochromic in 44.4%. Even there was evidence of microcytosis hypochromic anemia as well. Lymphopenia was seen in 65.2%, and 18% had thrombocytopenia at presentation. And when the CD4 cell count was less than 200 cell per count, anemia, the prevalence of anemia was seen in 91.4%, and leukopenia was in 6.8%, whereas lymphopenia and thrombocytopenia in 21.7%. So almost all studies till date which have been done on HIV positive patients and on the hematological routine hematological aspects of HIV hematology, they have found this nearly similar prevalence of anemias, leukopenia as well as lymphopenia and thrombocytopenia, which is also described in most of the Indian studies as well. Now, since we all know that HIV is the cause of depletion of CD4 positive T cells, because that is the primary target, so it is expected. So this to prove that this investigation in that says that in that immunophenotypic analysis, they have studied the immunophenotypic analysis of CD34 positive cell subset in bone marrow from HIV infected patients during highly active antiretroviral therapy. So what they did that is they took 12 HIV positive and 28 HIV negative control subjects, and both peripheral blood and bone marrow aspirate samples were subjected for flow cytometry using CD34 positive CD34 monoclonal antibody, and they studied the percentage of this. They analyzed this flow cytometric expression of CD34 before antiretroviral therapy at 4 weeks as well as 26 weeks after the initiation of therapy. So what they found was that before heart therapy was started, there was an increased CD34 positive cells. That means there was more number of progenitor cells which expressed both T and B cell markers. So that was CD34 positive progenitor cells that also were found to have a more expression of T cell markers and B cell markers both, and there was the proportion of CD34 positive cells with myeloid associated marker expression was less. Whereas once the heart therapy was started, so as expected, there was a proof that there was increased number of peripheral T cells and granulocyte. So that means the T cell population started increasing along with the TLC count, and the ANC also started increasing in the peripheral blood. There was a decrease CD34 positive cells that expressing T cell markers. That means which was more. Now the same population has decreased, and there is a decrease in serum IgG levels, and there is also a slight decrease in CD34 positive cells expressing B cell markers, and there was a significant increase in CD34 positive cells expressing myeloid associated markers. So this study proved that HIV causes blockage of T cell blockage, T cell depletion. There is a lack of differentiation of the T cells from progenitors to the mature T cell phenotype, and there is as a result of that, there is an accumulation of these T cell positive progenitors inside the bone marrow. However, once heart therapy, antiretroviral therapy starts, this block is released, and that leads to, or this heart therapy this inhibits this blockage, and this blockage of differentiation pathway of the T cell progenitors into a mature T cells, CD40 positive T cells. That's why in that way, this also discovery that this study proved that highly active antiretroviral therapy is very much useful in immune reconstitution in the subjects with HIV/AIDS. Now, with this, we will just now move towards known as bone marrow morphological approach. These are some of the cases which we have seen over the years in my previous institute at Pondicherry Institute of Medical Sciences, as well as at All India Institute of Medical Sciences, Bhubaneswar. Nearly 15 cases of HIV positive marrows we have done in both institutes. Many times nowadays this institutional protocol have changed. That's why we are not getting those cases of HIV positive marrows as often. And so I have just selected some of these cases. What we see that now, before I start these things, what are the diagnostic indications? What are the situations where this marrow examination in a HIV seropositive patient is needed or is indicated? And this both the textbooks as well as the literature says the similar things, that the bone marrow evaluation has significant importance in a setting of HIV positive in three major settings. Number one is, the first and foremost is evaluation of unexplained pyrexia, or there is no localizing signs of pyrexia, but there is patient present with pyrexia of unknown origin, the typical description of pyrexia of unknown origin. So so in this setting, that is the primary indication of doing a bone marrow sampling is for a microbiological culture of different types of microbiological cultures. That is the main purpose of doing a marrow at this setting. Of course, this HIV positive patients, they perhaps, as we see, we just saw in the previous slides, there is this evaluation of cytopenia, specifically immune thrombocytopenic purpura, that it is a definite indication of doing a bone marrow evaluation to see this cause of that prove that it is actually a case of immune thrombocytopenic purpura. Also, the evaluation of other cytopenias, also we need to know why this patient present with cytopenias. And of course, these patients are at risk of development of lymphomas known as AIDS related lymphomas. And so to exclude this, there is for the staging marrow, we need to do this marrow evaluation, as well as to rule out there is no involvement of this lymphomas in the marrow. Now, let us start with this case, that this is a 35-year-old HIV seropositive male who was not on highly active antiretroviral therapies, and who presented with fatigue and purpuric rashes. There was no organomegaly or lymphadenopathy. And CBC findings showed anemia. There is a MCB of 90 femtoliter, TLC 7,000, ANC is 2,245, platelet is 50,000 per cubic millimeter things, and CD4 T cell count was not there was more than 500, and reticulocyte count corrected was 1%. There was no biochemical abnormalities of B12 ferritin. Everything was in the normal limit, and patient blood and urine culture, there was no growth. So in this type of cases, there was, so basically this patient had a bicytopenia at presentation, and HIV seropositive. So what is the cause? That's why the patient was subjected for a bone marrow examination. And you can see that before that, this is the peripheral smear of this patient. What you can see here, that RBCs are basically more or less, there is reduced in density, there is normocytic, normochromic. There was no evidence of any cystocytes or any, because it is important that we sometimes HIV positive patients can present with microangiopathic hemolytic anemia or thrombotic thrombocytopenic purpura TTP like presentations. So we always must examine the peripheral smear for the presence of the cystocytes or fragmented RBCs, which was not there in this case. And there was a thrombocytopenia. As you can see that there is significant thrombocytopenia with some presence of some platelets here and there. Some giant forms were also evident. So there was anemia, there was thrombocytopenia, TLC count was, leukocyte was normal. And what was more significant in this case was the presence of this neutrophil predominance. There was significant lymphopenia, but all these neutrophils were morphologically abnormal. These neutrophils were smaller in size. There was hardly any segmentation which was visible. There was like a bilobed nuclei of most of the neutrophils, and it was like a pseudo pelgar-hued type of neutrophils which was seen in peripheral smear. This patient is a 35-year-old male, which is giving a hint towards a myelodysplasia like neutrophils that we see in patients with myelodysplastic syndrome. So when you did the marrow, so in the left hand side you can see that this direct smearing as well as cross or squash preparation of this bone marrow aspirate, which was particulate and which was hypercellular for age 35 years. And you can see that the central panel, you can see that there was the myeloid to erythroid ratio was almost 1:1, and there was slight erythroid predominance rather. And all these erythroids had a evidence of a binucleation. There was an internuclear bridging, there was a fraying of the cytoplasm, The nuclear chromatin was like megaloblast, like opened up chromatin, and there was, although there was no evidence of, of course, there are some of the cells had a irregular nuclear membrane outline. So all these pictures were suggestive of a dyserythropoietic changes which was dominating the marrow, and there was no evidence of ring sideroblast on Paulston. Myelopoiesis had an abnormally coarse granulation. There was not much of significant similar type of neutrophilic changes in the marrow, and there was no excess blast. Whereas the megakaryocytes were adequate in number, and as you can see here, there was a classically these are smaller in size. There was hardly an evidence of a nuclear lobation that is common for a normal megakaryocyte. So there was this megakaryocyte where they resembled like that of a myelodysplastic syndrome megakaryocyte or a dysplastic megakaryocyte. Whereas tryptophan biopsy was markedly hypercellular, there was myeloid prominence, erythroids were also there. There was no evidence of parvovirus infections or inclusions like things in the tryptophan as well as in bone marrow aspirate. And there was presence of this slightly dysplastic megakaryocyte which were clustered, and there was with a hypolobation, nuclear hypolobation, and on reticulin that stain that showed grade 1 to 2 fibrosis. So there was no evidence of any infections or any other specific related changes, and the culture of this bone marrow aspirate did not yield any growth. And so this that was called as HIV associated myelodysplasia like changes, which is very commonly seen in patients with HIV, and that is the cause of cytopenia in the peripheral blood. So while it is always, when we use the word dysplasia, it is also very much always, we must always remember that it is the HIV infections, the autoimmune disease like SLE, and last but not the least to forget a chronic binge alcoholics. So when we examine these patients, these morphological findings in the bone marrow aspirate and biopsy are so abnormal, so atypical, that can masquerade like myelodysplasia like changes. So which is very common. And in the right hand side, you can see, we all know that these are the different morphological features of dysbiosis. That article, this classic article by this Raznoldi et al. At in the Annals of Hematology 2005, you can see that this small megakaryocyte, hypo round megakaryocyte, pawn ball megakaryocytes, which is classically described in the myelodysplastic syndrome. In the central panel, you can see that this is nuclear lobulation, multiple nuclei, presence of ring sideroblast or macrocytosis, and this presence of the top, this granulopoiesis in the form of pseudopelgorute type of neutrophils, hypogranulation, hypergranulations, and no segmentation of the nuclei. All these features which are characteristic in the presence of a cytogenetic abnormality, we call them as myelodysplastic syndrome. But these three entities, anything can cause this type of changes, but these entities like HIV, one is SLE, another one is alcoholics, they also can have frequent this type of findings which can create confusion that of and mimic like myelodysplasia. So this is called as myelodysplasia like marrow changes in a patient associated with HIV. The second case, this is a 35-year-old female with a clinical diagnosis of prolonged fever or fever of unknown origin. There was no localized evidence of infections. She was found to be retroviral positive with CD4 count of 400. Bone marrow aspirate was nice, particulate, and it was called as a reactive marrow. No evidence of any dysplasia like in the previous cases. The culture was negative. There was no evidence of infections with the available special stains for the microorganisms. However, when the tryptophan biopsy came, the tryptophan biopsy was very classical. We always, when the clinicians will be very happy to see that when you tell them as a pathologist, we will tell them that yes, then there was no cause of pyrexia, radiology, nothing was revealing. But the bone marrow tryptophan, they always ask in the last resort for the evaluation of pyrexia. And in this particular case, there was a well-formed epithelioid granulomas, which was present with presence of Langhans type of giant cells, and there was patchy caseous necrosis. But we also did not find any AB in the but morphologically it was caseating epithelioid granulomatous inflammation, which was more in favor of a mycobacterial etiology. Patient was treated with ATT, and she had hot pyrexia subsided. This 35-year-old female retroviral positive with clinical diagnosis of prolonged fever, and there was significant generalized lymphadenopathy. There was no evidence of infection, and this patient presented with severe pancytopenia. And this I forgot to mention in this CD4 count was in this case was 150, and patient had pancytopenia. And when the marrow aspirate was done, when bone marrow aspirate was aparticulate, which was non-contributory. But when the biopsy was taken, the refined biopsy sections came that shows extensive myelonecrosis. So that proved that this case had this extensive HIV positive significant generalized lymphadenopathy and pancytopenia. The cause was actually the extensive myelonecrosis. And but we were not sure what is the cause of this myelonecrosis. Then this case actually was actually this by Professor Dr. Devadatta Basu from JIPMER Pondicherry. He has contributed, and when they came back and saw this again, they reviewed the bone marrow aspirate smear. This necrotic background, they had this type of negative staining, rod-like images, which was probably missed initially, and when they did this AB Jill Nielsen stain, that this case was these smears were loaded with acid fast bacilli. That means they highlighted that this was a case of extensive or disseminated mycobacterium tuberculosis with extensive necrosis that is the cause of pancytopenia. This is a 50-year-old male retroviral positive with prolonged fever, cough with expectoration, severe weight loss, and chest X-ray showed miliary shadows, which was suggestive of tuberculosis. However, patient presented with worsening pancytopenia with a hemoglobin of 3, TLC count of 2,500, platelet of 33,000. That means pancytopenia. And bone marrow evaluation was subjected done for evaluation of pancytopenia and pyrexia. However, the bone marrow aspirate was very difficult and it was aparticulate. So when we did this bone marrow aspirate, it was difficult and aparticulate. So this was the bone marrow aspirate, which was very scant, fluid-like. There was absolutely nothing, but only few areas this type of amorphous granular, this magenta color, this some matrix which was present here and there. There was no hematopoietic elements, no evidence suggestive of this any focal lesions, anything. Refined biopsy was markedly hypocellular. There was extensive, there was loss of fat, there was total atrophy of the fat, and this marrow was filled with this type of some mixed appearing areas which was confused with edema, or possibly that raised a suspicion of a gelatinous transformation. So we did this Alcian blue pH at 2.5, and that showed the presence of this bluish color, this hyaluronidase acid, which was that classical of the gelatinous transformation of marrow. And this patient, when we again asked the history of this patient, the residents told that there was a significant patient was highly cachectic, and he was critical, he was ill, and that possibly also corroborated this marrow appearance. That is the cause of, and in this case the accumulation of this hyaluronidase and this all this acid mucopolysaccharides, they are very toxic to the hematopoiesis. And there is no, this is nothing absolutely not related to HIV. This is just an associated complication of HIV or any debilitating disease that produces a significant weight loss, which was seen in this particular case. So then this was this paper we reviewed, that that was time there was from the in the JIPMER Pondicherry, this Sriya Das and Dr. Pritinanda Mishra, Rakhi Kaur and Devadatta Basu. They described this some gelatinous marrow transformation like changes in 11 cases, and of which and HIV positive was seen in 5 cases, and of which 2 cases had coexistent disseminated tuberculosis, one had Hodgkin lymphoma. So there they had different causes of gelatinous marrow transformation, which is not uncommon, and we should also be very much aware of these entities. This 29-year-old male, retroviral positive with prolonged fever, cough with expectoration, was admitted to the ICU. There was no localized evidence of infection, past history of tuberculosis, which was irregularly treated outside, and there was he had a features of sepsis with multiple organ dysfunction and severe pancytopenia. There was no blood culture available report of any growth, and there was severe pancytopenia and fever, and this bone marrow aspirate was scant, particulate, and it was difficult. So when we saw the aspirate in this side, you can see that there was a suppressed, there was a hypocellular bone marrow aspirate, and there was a suppressed trilineage hematopoiesis. There was no blast or no organisms, but there was, what was more characteristic of this was there was presence of this accumulated, when there are numerous histiocytic cells, reticuloendothelial cells, macrophage-like cells, which was numerous in there, And on closer up look, they also had evidence of increased iron as well as evidence of a focal hemophagocytosis. And on tryphin, there was again seeds of these histiocytes, non-epithelioid, non-granulomatous, no organisms, nothing, but there was no necrosis, no fibrosis, but the seeds of histiocyte engulfing the cells. So all these pictures, and when they, and we did, because of the histiocytes, a lot of histiocytes, AFB was done, which was negative, and then we asked for the ferritin, which was elevated more than 2000. Triglyceride was 320. There was rest, SGOT, SGPT, and all these pictures along with this clinical background in a setting of HIV positivity. This was taken as a case of an HLH, hemophagocytic lymphohistiocytosis, as a rare but definite complication of human immunodeficiency virus, which may be because of HIV per se, or maybe because of coexistent infections, be it disseminated mycobacterium tuberculosis, or any infections along with HIV can exacerbate this hemophagocytic lymphohistiocytosis. So when I was searching the literature about this entity recently, then I found this interesting article that in 20 it came in this Frontiers group of journals, that in 2020 recent article that hemophagocytic lymphohistiocytosis during HIV infection in when it is there, we must first think the presence of histoplasmosis. That means the most frequent etiology of HLH was associated infections, and that there was a confirmed histopathological diagnosis of histopathology. Histoplasmosis was seen in 10 out of 14 cases, and it was suspected in another 2 cases. And in all cases, CD4 count was below 200. HIV, there was a high viral load, and all patients when they were subjected to liposomal amphotericin B, and that was outcome was excellent in 12 out of 14 cases, and in 10 out of 12 cases involving histoplasmosis. So case fatality was only in 2 cases who had a fatal, and that means whenever we have a diagnosis of HLH in a setting of HIV, we must rule out all associated infections, specifically histoplasmosis. So this is just the summary of whatever the bone marrow changes that has been described in literature. This is from the Hobbrand's Hematology, 5th edition, 2005. And the marrow changes, characteristic of marrow changes, dysplasia is seen in 70% of cases in the marrow, and of which 60% cases show erythroid dysplasia, 30% cases show granulocytic dysplasia, and 40% show megakaryocytic dysplasia. Cellularity, as has been reported in the literature, is most of the times marrow cell is hypercellular, and more than 50% of cases. It can be hypocellular in up to 20% of cases. There is a chance of increased reticulin fibrosis in up to 50% of cases, and for which aspiration in HIV seropositive patients may be difficult to obtain. And iron stores may be adequate or even increased, which is not uncommon. That is, there is a defect in this iron reticulum, that macrophage to erythroid iron transfer. There is a block in that, so there is a chance in the anemia of chronic inflammation type of picture will be definitely present. So Paul stain is essential in all cases of HIV positive patients evaluated for any cytopenias. There is increased evidence of histiocytes, and which may show evidence of hemophagocytosis, which always needs to be taken into consideration. Plasmacytosis is a very common finding, which may show presence of atypical plasma cells. All opportunistic infections are always to be looked for: Mycobacterium tuberculosis, atypical mycobacteria, histoplasma, leishmania, cryptococcus, pneumocystis, to name some few. Any infection can be there, but these are the common things that which always look for. Granulomas are common, but usually of cryptococcal or mycobacterium tuberculosis. Indian context, we always would look that for mycobacterium tuberculosis. But any infection, that the list of granulomas in marrow is can, whatever may be the granulomas condition causes, that has to be evaluated. Lymphoid aggregates are very common in marrow's tryphins of patients with HIV/AIDS, and of course, is the AIDS-related lymphoma. 20% of patients with AIDS-related lymphoma have marrow involvement. So all these things summarizes the bone marrow changes in a patient with HIV/AIDS. Now coming to this AIDS-related lymphoma or ARL, this in contrast to this, this is the recent data suggests that there is a very significant incident, the rise in incidence of this lymphomas compared to general population among all HIV or AIDS patients. In contrast to this general population, lot of population based studies, many cancer based registry based studies have found that there is a nearly 100 to 200 chance of risk of development of a lymphomatous malignancies in HIV positive or AIDS patients in comparison to this normal healthy general population. And majority of this hematolymphoid malignancies are actually non-Hodgkin's lymphoma, which is more than 50% cases is actually non-Hodgkin's lymphoma, and among which immunoblastic and diffuse large B-cell lymphoma is more common, followed by this Burkitt morphology of nearly 25% of all systemic NHLs are Burkitt. Plasma blastic lymphoma occurs in up to 5% cases with HIV positive patients. But nowadays also, and they are more commonly of an head and neck origin. But nowadays also we see a lot of cases of plasma blastic lymphomas even in immunocompetent individuals. Hodgkin lymphoma incidence in comparison to the normal HIV negative individuals also significantly there is a high risk of development of Hodgkin lymphomas. More commonly of mixed cellularity as well as lymphocyte depleted phenotype are commonly seen among Hodgkin phenotypes. Primary CNS lymphoma up to 15% cases in an HIV positive patient is an AIDS related defining diagnosis, primary CNS lymphomas, as well as primary effusion or body cavity lymphomas, which are seen in up to 6% of cases of things. So what is the exact mechanism that is postulated is that as you know that this HIV depletes the CD4 positive T cells, and we all know that CD4 positive T cells are the master regulator of the immune system. They regulate the proliferation and production of this B lymphocytes by means of both autocrine as well as paracrine functions. So once there is a depletion of CD4 positive T cells, there is increased proliferation of B lymphocytes, because the proliferation of B lymphocytes, they remain unchecked. So what happens initially, there is increase these B lymphocyte proliferations are polyclonal, and that produces a polyclonal hypergammaglobulinemia. And in the setting of this B cell proliferation, there is a infection. B cells has a receptor for infectious mononucleosis EBV Epstein-Barr virus, as well as there is also reports that other infections like hepatitis B virus, hepatitis C virus, and human T cell lymphotropic virus HTLV can also play a role for this. And there is an increasing evidence that it is the BCL6 overexpression that is seen in up to 70% of cases of this non-Hodgkin's lymphomas, and nearly 100% cases of this lymphomas, they express MIK gene rearrangement. All these things leads to this conversion of this polyclonal B cell proliferation to a monoclonal cell proliferation, that is what is known as a lymphoma, B cell lymphomas. So there have been some prognostic parameters of these things. Major adverse prognostic parameters in AIDS related lymphoma is there is a prior AIDS diagnosis, which is a major adverse prognosis factor. That means a person who is not diagnosed as AIDS is probably will do better. So once there is a diagnosis or prior diagnosis that it is AIDS, that has a adverse prognostic outcome. CD4 T cell count less than 100 is an adverse prognostic parameter. ECOG performance status greater than 2, and presence of primary CNS lymphoma. These are considered to be this major adverse prognostic parameters, whereas bone marrow involvement of any of these lymphomas is not a major adverse prognostic parameters. It is considered as a minor adverse prognostic parameters. And presence of extranodal disease, raised serum LDH, and age more than 35 years. So these are considered to be as minor adverse prognostic parameters in AIDS related lymphomas. So I would like to summarize what I have told today till now, that we all know that there is a, so when you have a deranged hematological parameters, so there is what is you know that this maybe have a multifactorial basis. HIV infection itself causes infection of the marrow progenitors, and all the stromal microenvironment is infected, as we have seen with foolproof evidence. And that is the main thing, that HIV directly infects the progenitor cells that causes cytopenias. HIV is a state of immunosuppression. and immunosuppression, as I discussed just now, is a risk factor for development of neoplasms, that is lymphomas. And lymphomas may produce cytopenias or secondary hematological abnormalities secondary to this marrow involvement of AIDS related lymphomas, or any lymphomas can also have a high propensity of marrow involvement, suppressing the hematotriliniase hematopoiesis. Maybe another reason, these lymph neoplasms, this the chemotherapy related cytotoxicities is a significant contributor of development of this hematological derangement. Opportunistic infections are very common in patients with HIV, and they directly will produce the infection of this marrow, opportunistic infections of all sort of opportunistic infections, as a major cause of cytological abnormalities as well as morphological and numerical abnormalities of this peripheral blood. And the therapy that is given for these opportunistic infections, we should always be kept in mind, that is presence of therapy that is for infections and their toxicity, that is also have to be kept in there things. And also last but not the least, HIV infections, this highly active antiretroviral therapy which is given against HIV infections, zidovudine, of all this highly active antiretroviral therapy, zidovudine has the maximum cytological toxicity among these stromal progenitors. It is said that this zidovudine can cause pure red cell like aplasia like changes in the erythroid progenitors, mimicking parvo B19 infections. And that's why, and also this zidovudine is a cause of B12 malabsorption, that is also is a cause for this presence of these hematological parameters. So this I love reading this textbook, this postgraduate hematology by Hobbrand, Katowski, and Dudenham. This is the 5th edition. What I want to highlight here is that this, after this edition, when 6th edition came, this particular chapter was very much minimized, and so those who are interested to read about the hematological aspects of HIV disease, this textbook, and that to 5th edition 2005, 5th edition is beautifully, this Christine Costello has beautifully depicted these different aspects of HIV and hematology. And also these are my further suggested reading, and that zidovudine, this is the recent article in Indian Journal of Pediatrics, zidovudine induced anemia in HIV AIDS. And also this is in the 2021 recent publication in the International Health, that anemia and thrombocytopenia in people living with HIV AIDS, a narrative literature review. So at the outset, so we all must understand that patients of HIV AIDS must never be discriminated while they evaluating for their any sort of evaluation, be it diagnostic approaches. So while we must follow the strict precautions, so that universal precautions while carrying out any hematological or any other lab related test, including invasive procedure like bone marrow, we need to be very careful. While evaluating the patients of we must be very much aware of this diverse aspect of HIV, its associated complications as well as opportunistic infections, the drugs, and we must have a proper drugs therapeutic history, so that to give a proper morphological approach to this peripheral smear abnormalities, CBC abnormalities, and the bone marrow abnormalities, which is essential to fulfill this or to answer the queries raised by our clinical colleagues, that why my patient is having all sort of hematological abnormalities. We need to answer to them with meticulous precision and with a proper mathematical morphological approach. Thank you so much, Dr. Nadeem, sir, and all my teachers, my fellow colleagues in my department, as well as especially my previous institute at Pondicherry Institute of Medical Sciences, where nearly 6 or 7 cases of HIV. We did marrows and we discussed, we found out a lot of the morphological changes. We read at that time with my fellow colleagues there, and also here also at AIIMS Bhubaneswar, uh, the sporadic HIV positive cases. Keep on educating us, and we would love to be always educated in days to come, because we always believe that it is the patient that is the ultimate teacher, no one else. Thank you so much, sir. Thank you so much, everyone.
Thank you so much, Dr. Somanath Padhi. Excellent presentation. and very well summarized. And thank you for sharing the references. Becomes very important for everybody to go back and refer to that. You are absolutely perfectly correct. I mean, with the myriad of things which HIV has, and the hematological manifestations can be viral associated, can be cytotoxic drug associated, can be OI associated, and long term anomalies like lymphoproliferative disorders can also be there. And it's a very complex subject, and you have dealt with it so nicely, so smoothly, and so vividly. So thank you so much. You are a very nice teacher, very, very good teacher. I mean, you really teach very well.
Thank
And
you so much.
it's an art which very few people have, and I think you possess that very well. You're a very good teacher, and the way you taught every bit of it, and the way you went through, starting from one point to the other, and then going to the cases one, two, three, four, five, and it was wonderful. I mean, even
Thank you, sir.
even people with basic knowledge will be able to understand everything. HIV is a very difficult subject, and you made that hematological manifestation look so simple. Thank you so much. We'll be looking forward to your next lecture. I think that is on congenital dyserythropoietic anemia. That is somewhat time in the end of this month.
Yes, sir.
Uh, we'll be waiting for that, and definitely after that we will not let you go. Maybe sometime later we will ask you to come and teach more and more. You are a wonderful teacher, excellent teacher. You have real teaching skill, and it's an art very few people possess, and you are gifted with that. Thank you so much.
Actually, my all this acumen, actually the credit goes to the students and the postgraduate students, as well as the clinical colleagues with whom I always interact, and I tend to know, I try to understand what exactly they want, what exactly their patient want, they need. And always I discuss with my fellow departmental colleagues. We rag each other. My habit has been to rag each other and to get doubts on table cleared, and which has actually helped me. And I was a very nervous orator when I was in my infantile stages. Thankfully I have somewhat I'm learning, and it's wonderful listening to your kind words of appreciation, sir. And thank you so much, sir. Thank you.
My pleasure. The pleasure is all ours. I mean, I have been going through many lectures, and I can say from the bottom of my heart that you are a wonderful teacher. Thank you so much. It was nice having you here on the platform, sir, and we'll welcome you again. Take care. Good night. Bye bye. God bless you.
Thank you, sir. Thank you, sir.